This is Dr. Zepchinsky. This presentation is from Chapter 40 in the primary care text, Gastric and Intestinal Disorders. Topics covered include gastroesophageal reflux disease, or GERD, peptic ulcer disease, which is gastric and duodenal ulcers, hemorrhoids, abdominal hernias, including inguinal hernias, irritable bowel syndrome, celiac disease, bowel obstruction, diverticular disease, inflammatory bowel disease, Crohn's and ulcerative colitis, and colorectal cancer. Gastroesophageal reflux disease, or GERD, is actually a syndrome of signs and symptoms. There is a difference between GERD with a D and GER. Gastroesophageal reflux occurs in most people. Gastroesophageal reflux disease is a lifelong condition that requires monitoring and care so that there is not damage to the mucosa that leads to cancer. The relaxation or pressure that overwhelms the esophageal sphincter allows reflux of stomach contents into the esophagus. Remember that the stomach and the duodenum, the first part of the small bowel, the pH is very acidic, and that the reflux of those contents into the esophagus can cause burns to the mucosa, and that's what gives us symptoms. Now, these symptoms occur without retching or vomiting. These can be from lifestyle such as stress, smoking, alcohol, eating before going to sleep, tight clothing, heavy lifting that increases abdominal pressure, caffeine, and risk factors include obesity and being overweight. Presentation is often subjective complaints of heartburn or water brash, which is that kind of a burp that tastes like stomach contents, dysphagia, which is difficulty swallowing, a sour taste, odonophagia, or some difficulty with chewing, belching, coughing, hoarseness, and wheezing. These can range from mild to severe. It's important to get a thorough history and to perform a focused physical exam. One thing to think about is that dysphagia with GERD often occurs with the first swallow of every meal, and then it goes away. Any type of dysphagia that persists or is progressive, then we start to suspect that there is maybe a stricture, the food won't go down, or some sort of a cancer. The history is important in differentiating GERD from other disorders. Heartburn from peptic ulcer disease is relieved by food. Heartburn from GERD is worsened by food. Gallbladder disease is usually associated with epigastric pain and nausea, usually after an ingestion of a high-fat meal. And GERD may present with chest pain, which makes it even trickier to try to figure out. While reading your text and listening to these PowerPoints, pull the Rome 4 criteria and read the descriptions. These criteria will help you understand the importance of taking a thorough history in whittling down the differentials and coming to the diagnosis. You will notice that much of the diagnostic criteria is based on the history and physical. Diagnostic tests help us rule in or rule out specific disorders. Diagnosis for GERD is generally made by the history. Keep in mind that adults with GERD may present with adult onset of asthma, complain of chronic cough, laryngitis, sore throat, and they may present with non-cardiac pain. A 2-week trial of a PPI with resolution of symptoms is diagnostic for GERD. The gold standard is an EGD. The American Association of Gastroenterologists recommends an EGD for patients with heartburn and dysphagia, bleeding, anemia, weight loss, recurrent vomiting, and persistent symptoms of greater than 8 weeks rather than an initial empiric therapy of a PPI. Surveillance evaluation for a Barrett's esophagus is every 3 to 5 years or more often if there is progression of mucosal damage. Management goals for GERD are to rapidly eliminate or reduce the symptoms, make the person feel better, prevent meal or exercise-related symptoms, and prevent complications such as Barrett's esophagus, esophageal strictures or ulcer, aspiration into the lungs, esophageal hemorrhage, and to be as cost-effective as is possible. This is a clinical scenario of a 64-year-old white woman with a history of 2 gastric bypasses. These bypasses were not for weight loss. She had had Nissen fundoplication twice to correct a hiatal hernia. The hernias recurred and each ruptured. Gastric bypass was done, which left her with a small wedge of stomach. She continued to have reflux disease and was eventually diagnosed with Barrett's esophagus. Barrett's esophagus is a change in the normal mucosa of the esophagus caused by constant erosion, irritation, and inflammation from the gastric acids. It is considered precancerous and it can progress. When the lady came in, she actually hadn't had a scope in about 7 years. She had no insurance and had lost her primary care provider. Fortunately, there are some clinics that take patients on a sliding scale or for free, and she was able to get an upper and lower endoscopy, and fortunately for her, it showed that her Barrett's was stable and that she had no progression. To manage the GERD, she had been on and continued to take a PPI, omeprazole, and Carafate was added. Now, Carafate was added to give her an extra layer of protection in her lower esophagus. So this would be a good time to look up the action of Carafate and understand how the drug helped her and when you might be able to give Carafate to someone that you see in practice. The goal of treatment is to rapidly reduce or eliminate symptoms. We want to make the patient feel better sooner rather than later. Also, we want to prevent meal or exercise-related symptoms. These are lifestyle, quality of life issues. And especially, we want to prevent big complications such as esophageal strictures, Barrett's esophagus, which is a precancerous condition, pulmonary aspiration, and esophageal hemorrhage. These complications occur over time, sometimes years. Some patients have silent reflux and they have no symptoms until they develop a stricture or another problem. The focus of management is patient education plus pharmacological intervention. For mild intermittent symptoms, the American College of Gastroenterologists conditionally recommends lifestyle modifications, which includes weight loss, elevating the head of the bed 6 to 8 inches, avoiding a meal 2 to 3 hours before bed, and avoidance of specific trigger foods. Also, they include an 8-week trial of proton pump inhibitors. Different PPIs, it doesn't matter. You can look at the chart for a selection of them and look at their dosing. The PPI is to be taken once a day. Typically, you start 30 to 60 minutes before the first meal, breakfast, which tends to be most effective. For those that have a partial response to this treatment, we can change the schedule of when the PPI is taken. Instead of taking it in the morning before breakfast, they could take it at nighttime if, especially, they get nighttime acid reflux. We can also change the dosing to BID. Or increase it to BID. We can have them take a pill in the morning before breakfast and then in the evening before their evening meal. We can also switch to a different PPI. Most people are going to have a decrease in symptoms of heartburn and some healing of their erosive esophagitis, if that's what's there, with the BID dosing. People that have severe erosive esophagitis or Barrett's are going to have to be maintained on long-term therapy. 80% of patients will relapse eventually, and they will require some intermittent therapy. Now, this may seem confusing, but remember that GERD is a disease. That's what separates it from esophageal reflux. It's a disease. There are changes in the mucosa of the esophagus, and there's the relaxation of the sphincter. And these medications and lifestyle changes can be effective, but they may be lifelong. Also, a person who has Barrett's esophagus or erosive esophagitis is going to have to be followed up by the gastroenterologist frequently for EGD to make sure that they are not progressing in the disease towards a cancer. Having said that, people who have mild or intermittent disease and they get better on an 8-week course of PPI, it's important to get them off a PPI. Yes, they may relapse, but what we've seen is that people sometimes are on PPIs for years and nobody has noticed this. And PPIs can cause side effects such as PPI-associated pneumonia, but bigger ones are Clostridium difficile, because it changes the gastric pH and therefore it will change the pH of the GI tract. The other is vitamin B12 deficiency. The mechanism for absorbing vitamin B12 begins in the gastric area, in the stomach, where the pH is very low. That is required to break down the proteins in which the B12 is so that we can absorb it. But when we change the gastric pH with a proton pump inhibitor, then over time this can cause a decrease in the absorption of vitamin B12 and lead to a deficiency. Peptic ulcer disease is an umbrella term that includes gastric and duodenal ulcers. Gastric ulcers occur in the stomach, while duodenal ulcers usually occur in the duodenum, which is the first part of the small intestine. To understand how the symptoms occur and what the treatment plan is, let's review the anatomy and physiology. The stomach has 4 areas. The top is the cardia, followed by the fundus, which is the upper part of the stomach shaped like the fundus of a gravid uterus. The body, which has a lesser and a greater curvature, and the pyloric antrum or pylorus. The cardia contains the lower esophageal sphincter, which allows food into the stomach. The pylorus contains the pyloric sphincter between the bottom of the stomach and the duodenum, which is the first section of the small intestine. The pyloric sphincter closes while we eat to keep food inside the stomach for digestion. Now, each of the stomach sections secretes different substances. The cardia secretes mucus, while cells in the body of the stomach secrete both hydrochloric acid and pepsinogen, which is a digestive enzyme. The pylorus, duodenum, and the pancreas, which is an accessory organ, secrete gastrin. Gastrin stimulates the production of hydrochloric acid, which is necessary for initial breakdown of food. The duodenum has glands called Brunner glands, which secrete mucus that is rich in bicarbonate into the small intestine. That's important because with all the acid and the enzymes, digestive enzymes, floating around in the stomach and duodenal mucosa would get digested if not for the mucus coating the walls and the bicarbonate ions secreted by the duodenum, which neutralize the acid. Additionally, prostaglandins get secreted in the stomach and duodenum that trigger more mucus and bicarb secretion. Remember that the stomach has a very low pH, between 1 and 3, which would digest the stomach mucosa if it were not protected by mucus and bicarbonate. So let's look at the pathophysiology here. Gastric ulcers tend to occur in the lesser curvature of the antrum. Duodenal ulcers tend to develop right after the pyloric sphincter, right in the beginning of the duodenum. The most common cause of peptic ulcer disease is infection by Helicobacter pylori. This is especially so in low-income countries. H. pylori is a gram-negative rod bacteria that invades and colonizes the gastric mucosa. These bacteria secrete adhesins, which help them stick to the mucosal cells, and they also secrete proteases, which damage the mucosal cells and help them really get a foothold. Over time, the bacteria damage erodes deeper and deeper into the mucosa and eventually causes ulcers. Now think about where these ulcers are. If they're in the stomach, they are exposed to constant churning of digesting food and hydrochloric acid. So if you're looking at them visually, they're going to look punched out or clean. They're not going to have any debris in them. Another cause of gastric ulcers are chronic NSAID use, such as low-dose aspirin and ibuprofen. NSAIDs work to help with pain and inflammation by inhibiting inflammatory prostaglandins, but that in turn leaves the gastric mucosa open to damage. Remember that prostaglandins stimulate the release of mucus and bicarbonate. Very deep ulcers in the stomach or in the duodenum can erode into blood vessels and cause bleeding. Occasionally, the erosion occurs into an artery that can cause rapid blood loss and shock. Think about the stomach and the lumen of the intestines as being open. You can bleed very quickly into that space. The perforation occurs when the erosion goes so far that it just eats completely through the wall of the stomach or of the duodenum. And this can cause leakage of gastric contents into the peritoneum. So think peritonitis. This allows air to collect under the diaphragm, which then irritates the phrenic nerve, causing referred pain up into the shoulder. That can also occur with things like cholestasis or cholecystitis. Long-standing duodenal ulcers that occur near the pyloric sphincter can become edematous and so scarred that food cannot get through and can create an actual gastric outlet obstruction, and an obstruction is accompanied by nausea and vomiting. Presentation. Duodenal ulcers are more common in people between the ages of 30 and 55, so sort of middle age, while gastric ulcers are more common between the ages of 55 and 70. They occur more in our elder population. Most ulcers occur in the duodenum close to the pylorus. The hallmark presenting symptom is a complaint of burning or gnawing sensation or pain in the epigastrum or the upper abdomen, which is relieved by food or by antacids. Gastric ulcer pain tends to increase while eating because of the presence of food and the stimulation and secretion of hydrochloric acid. Because the pain increases with eating, gastric ulcers are often associated with weight loss. Peptic ulcers, on the other hand, tend to be relieved by food. These can be associated with some weight gain. Nocturnal pain is present in about 2/3 of the people with duodenal ulcers and about 30% of people with gastric ulcers. Just know that nocturnal pain follows a circadian stimulation of acid secretion. So acid secretion may increase at night and people may respond with pain, complaints of pain. Be aware of any red flags, such as vomiting and weight loss, melena, coffee ground emesis. You need to consider a malignancy, a GI bleed, or a gastric obstruction. For peptic ulcer disease, the history is going to give you most of the information you need to formulate your differentials and diagnostic plan. Objective findings from your physical exam may be normal. There may be some tenderness in the epigastric region, depending on the size and the location of the ulcer. Differentials include GERD, gastric cancer, myocardial infarction. Remember that not all abdominal pain is from an abdominal organ, gastritis, and gastroenteritis. The standard diagnostic for peptic ulcer disease is the EGD for visualization of the ulcer and biopsy for malignancy and H. pylori. Other diagnostic tests can be a CBC if you suspect anemia or bleeding. With elevated white blood cells can occur with a perforation. Suspect H. pylori if there is an unexplained iron deficiency, vitamin B12 deficiency in otherwise healthy people. Remember that this disease can often be silent. H. pylori causes 90 to 95% of gastric and duodenal ulcers. So you can test for this by using a fecal antigen test, a serum ELISA, IgG, the urea breath test, or when you send them for the endoscopy so that they can have a biopsy to rule out malignancy and test for H. pylori. The goals for managing peptic ulcer disease are fourfold. Number 1, relieve the pain as ulcers hurt. 2, heal the underlying ulcer. 3, prevent complications such as anemia from chronic bleeding and perforation of the ulcer. 4, prevent recurrence, especially gastric ulcers. They tend to recur. Non-pharmacological include smoking cessation. Any patient that's smoking needs to be approached every single time they come for a visit, as smoking delays healing by constricting blood vessels. The pharmacological drug of choice is the proton pump inhibitor. The duration of action is more than 24 hours, making once-a-day dosing possible, and this helps a lot with compliance. The type of PPU is up to you as provider, so omeprazole is commonly chosen. In patients that have very few symptoms and no indications of any complications, you can do a trial of H2 receptor antagonists such as cimetidine or any of the other itidines. But keep in mind, Tagamet competes with the hepatic CYP450 system and can increase levels of warfarin, theophylline, and phenytoin. Now, warfarin is Coumadin and phenytoin is Dilantin. And it doesn't matter whether it's prescribed by you or they pick it up over the counter. If you've got a patient taking any of those drugs, you need to educate them about that. Other choices are sucralfate, which is an aluminum hydroxide salt of sucrose or sugar that helps form a protective barrier to acid and pepsin. Dosing is 1 gram 4 times a day, and it works as well as the H2RAs. Prostaglandin analogs can also be used, such as misoprostol, which is Cytotec. It also acts by protecting the stomach against acid damage and decreasing acid production. But FYI, Cytotec is the same agent that's used to ripen a cervix for labor induction, and it should not be anywhere near a pregnant woman. Other choices include bismuth subsalicylate, which also protects the lining of the stomach. Any patient with a gastric ulcer should be referred to GI because these tend to recur and gastric cancer risk is increased. This is a list of the common over-the-counter antacids that we use to treat peptic ulcer and gastric ulcer disease. Helicobacter pylori causes 80 to 90% of peptic ulcers, so part of the treatment is to eradicate that bacteria with a combination of antibiotics plus a proton pump inhibitor. Most regimens for treating H. pylori will combine antibiotics and PPIs for 2 weeks. There are 2 types of therapy we'll talk about. First is the standard triple therapy that combines 2 antibiotics, clarithromycin, which is a macrolide, 500 milligrams twice a day, and either amoxicillin, which is a penicillin, 1 gram BID, or metronidazole, which is an antimicrobial drug, 500 milligrams twice a day, plus the PPI twice a day for 14 days. Amoxicillin is preferred over metronidazole, first because there is resistance of H. pylori to metronidazole, and second, metronidazole can have some adverse effects, such as a metallic taste in the mouth, that may cause noncompliance. The other type of therapy is quadruple therapy. That's 2 antibiotics plus a PPI and adds bismuth. Remember that bismuth works by protecting the mucosa and stimulating the creation of bicarb. So this quadruple therapy includes tetracycline, 500 milligrams 4 times a day, metronidazole 500 milligrams 3 times a day, a PPI twice a day, and bismuth either 2 or 4 times per day. Eradication of H. pylori needs to be confirmed 4 weeks after the completion of the therapy to make sure that it is actually gone. Hemorrhoids are enlarged anal veins. They are dilated and tortuous veins in the submucosal tissue of the rectum and anus. This picture shows the position of the internal and external hemorrhoidal plexuses. That's what your book refers to these areas as. Other sources of anatomy call them cushions or anatomical hemorrhoids. But these plexuses are specialized submucosal tissue that are connections between arteries and veins, so they're very vascular. They are also supported by smooth muscle and connective tissue and help to control anal continence. Internal hemorrhoids develop from the internal hemorrhoidal plexus, which is in the upper anal canal and the lower part of the rectum. You can see there all those little rectangle-like areas. That's all part of the internal hemorrhoidal plexus, and it's fairly long on this picture. The external hemorrhoids develop from the external hemorrhoidal plexus near the opening of the anus, and it kind of makes sense, doesn't it, that external hemorrhoids are going to be those that are really close to where the anus opens, whereas internal ones are higher up. A prolapsed hemorrhoid is an internal hemorrhoid that has enlarged enough to actually fall through the anal opening. Hemorrhoids are most commonly associated with constipation and straining during BMs. They can also occur in pregnancy, obesity, with increasing age, anything that increases intra-abdominal pressure, such as weightlifting, chronic coughing. Pregnancy causes hemorrhoids because of the constipation in later pregnancy, pressure from the baby, and the relaxation of pelvic structures by hormones. Generally, hemorrhoids can be asymptomatic. Many people are walking around with them and they don't know they have one. External hemorrhoids can be painful. Think of the anatomy of that dentate line. These are skin or epithelial cells that are sensitive to pain. These patients may complain of abrupt onset of pain, pain that occurs with a BM, a sore or itchy anus, mucus discharge, and a palpable lump at the anus. Internal hemorrhoids, these are painless for the most part until they become prolapsed. These are above the dentate line where the cells are like those of abdominal organs, so the pain is vague. They may feel rectal fullness or a little discomfort. The most common symptom of hemorrhoids is painless rectal bleeding, bright red blood on the toilet tissue or blood dripping into the toilet. This blood is not mixed with the stool. That would lead you to a different differential. Thrombosed hemorrhoids are intensely painful. Blood pools and clots, and the area becomes swollen, inflamed, and a person may have trouble walking. Blood and intense pain are symptoms that bring patients either to your clinic or to the ER for evaluation. Once you've taken a good history from the patient, you're going to do the physical exam, which consists of inspection of the anus and surrounding area. Position the patient lying on their left side with their knees bent up towards the chest. This is most comfortable and will help us visualize the area. Use a clock face to document the position of the hemorrhoid. 12 o'clock is going to be pointing towards the genitals, 6 o'clock towards the tailbone. Now, hemorrhoids may not be visible until you have the patient bear down or perform some sort of Valsalva maneuver. Thrombosed hemorrhoids, where blood has pooled and formed a clot, may look shiny or blue or as a hard, discolored lump at the anus, and it's going to be tender. You may see skin tags or scar tissue at the site of resolved thrombosed hemorrhoids. These tend to resolve themselves in about 3 weeks. Classification of internal hemorrhoids. This has to do with degree of prolapse from 1 to 4. The first degree has no prolapse. A second degree, you'll see the prolapse of the internal hemorrhoid with straining. Once they relax, it returns back into the anus. Third degree occurs with straining. It doesn't return on its own, but it's easily reducible. You can push it back inside. And a fourth degree internal hemorrhoid remains prolapsed. It will not go back up, and you cannot push it back up. The differentials include polyps, anal carcinoma, anorectal fistula, and rectal prolapse. A couple of others are cryptitis and papillitis, which are changes in the intestinal mucosa that can be from inflammatory bowel disease. Usually the history and inspection are adequate to diagnose external hemorrhoids. Digital rectal exam is not recommended. Internal hemorrhoids require an anoscope or a proctoscope or sigmoidoscope in order to be definitively diagnosed. Management includes symptomatic treatment for external hemorrhoids. The goal is pain relief and prevention of further hemorrhoids. For pain relief, you can use an oral analgesia such as ibuprofen or acetaminophen, and a sitz bath, which is a shallow bath that bathes the genital and anal area. It's quite effective in pain relief. It's used often for women after an episiotomy. We're going to teach them about decreasing straining. That means avoiding long sitting on the toilet. Using a bulk forming laxative such as Metamucil, Fibercon, something like that. Increase the fiber to 25 to 35 grams per day. Over here there's a picture of different types of vegetables and the grams of fiber. So this is what 30 grams of fiber looks like. Okay. Pruritus can be a problem. For that, we can offer a topical hydrocortisone cream. Witch hazel, which is kind of comes in an alcohol looking bottle, but it says witch hazel and has a distinctive smell. Again, sitz baths. Internal hemorrhoids, we're going to use the same treatment as above. We're going to add fiber, increase fluids, and add bulking agents. Non-surgical treatments, when symptomatic treatment fails, include sclerotherapy, where there is a sclerotic formula that is injected into the hemorrhoid to cause it to scar, infrared coagulation, rubber band ligation. Rubber bands are actually applied. These are tiny rubber bands applied to the hemorrhoids to cut off the blood supply and form scar tissue. These procedures require repeating several times every 3 to 4 weeks until resolved. When all else fails, the internal hemorrhoids can be removed surgically. This section is on abdominal wall hernias. The abdominal wall is made of complicated layers of muscle and fascia. Fascia is a thin connective tissue that surrounds and holds every organ, blood vessel, bone, nerve fiber, and muscle in the body in place. There are areas in the abdomen in which fascia is not supported by muscle or much muscle. These include the linea alba, which is the white line in the first picture that runs down the middle of the abdomen from the rib margin to the pubic bone. Other areas, such as the umbilicus and the inguinal canal, have a small ring of fascia that is not supported by muscles, and these are common places for hernias to develop. A hernia is the protrusion of a peritoneally lined sac through a weak place or defect in an abdominal wall. Essentially, a hernia is the protrusion of the intestines, usually the small intestines, into a defect in the abdominal wall. Contributing factors include increased intra-abdominal pressure, such as you see from ascites, obesity, people who do heavy lifting, pregnancy, and aging with its concomitant loss of collagen, which weakens the abdominal wall. Also, defects come from old scars, such as appendectomy, gallbladder, a previous hernia repair. Hernias are named by their anatomical location. Midline or ventral hernias occur on the anterior abdominal wall and include umbilical, epigastric, incisional hernias. An incisional hernia can occur anywhere along a surgical incision. In children, umbilical hernias are considered normal until age 2. Groin hernias, or inguinal and femoral, are the most common type of hernia found in men and women. This area has only a small ring of fascia that is unsupported by muscle, and with the right conditions, a loop of bowel can slip into that area. Hernias can be chronic or they can be acute. Acute hernias are those such as incarcerated hernias. They're not reducible, you can't push them back in, that cause a bowel blockage. The second type is the strangulated hernia, not reducible, and it cuts off the blood supply to that part of the bowel. Both of these are surgical emergencies. For clinical presentation, know that some hernias are obvious. The patient may come in complaining of a lump or a bulge in the abdomen or groin. Some people know they have a hernia and are aware when there's a change. The weakness in the abdominal wall muscle occurs over time, years of coughing, obesity, or heavy lifting. And one day a patient may lift a child or something really heavy or cough and feels a pop as the weak muscle gives way. There may or may not be pain with a hernia. Pain can be an important clue. Dull, crampy pain may indicate that something's stuck. Pain may be relieved by pushing the hernia back in, especially in the groin. There are patients who don't know that they have a hernia, and that's found on examination or what we call incidentally. So get a good focused history. Ask about things that increase intra-abdominal pressure, like heavy lifting, chronic cough, chronic constipation, or BPH in men, because straining to urinate, it does increase intra-abdominal pressure. Also get a good surgical history. Your physical exam will focus on the GU, respiratory, and GI systems. Why? Well, respiratory, because some of the epigastric hernias can be quite large and push up on the diaphragm, interfering with breathing. Begin by inspecting the abdomen. If it's truly a ventral hernia, have the patient lie on the exam table and look. If the hernia is not visible, ask the patient to bend their chin to the chest and see if that makes the hernia visible. That actually works. I had a student bring their father in for a 5700 checkoff, and when the dad lifted his chin to his chest, this tremendously large hernia popped out. So inspect the inguinal hernias in males with them standing. You're going to have to palpate the scrotum for contents, okay? And then continue by gently invaginating the scrotum up until the inguinal ring. Have the patient cough, and if they have a hernia, you should be able to feel it bump against your finger. Any male that presents with an abdominal hernia needs a prostate exam, and this is to ensure that there is nothing keeping the bladder from emptying. Large hernias need to be examined for incarceration and obstruction. Can you reduce the hernia? Can you push it gently back inside? If not, then a part of the bowel may be caught outside of the ring, of the defect ring. So we'll need to classify the hernia as to whether it's reducible. That means you can easily push it back in. It's not reducible. It won't go back in. It's incarcerated or causing an obstruction of the bowel, but not necessarily the blood supply, and whether it's a strangulated hernia. Strangulated means the blood supply has been cut off and the person is in danger of shock. There are red flags: severe pain, swelling or redness at the site can indicate a decrease in the blood supply, along with fever and chills. Think about shock. If the hernia grows rapidly, you could trap so much of the bowel outside of the body that you can't reduce it. Nausea or vomiting and no passing of gas or having a bowel movement. That can happen when a loop of the bowel gets stuck, and although the blood supply is not compromised, the lumen of the bowel through which the feces moves is obstructed. Hernias happen over years of wear and tear. Most will not get better on their own. The exception to that is a child with an umbilical hernia, and usually by the age of 2, it closes on its own. Not all hernias need to be fixed. Hernias that are in the groin and are asymptomatic bear watchful waiting. Some may get a CT or an ultrasound to see what's inside the hernia, whether there's fatty tissue or a bowel. But you can refer the patient to a surgeon if you think that it is bothersome, it is growing, there is pain, it's not reducible. Those types of things need to be referred. Also, any emergency with redness, severe pain, etc. needs to be sent immediately to an ER. Then think about the patient education after the hernia repair. The most important thing is to allow the abdomen time to heal before resuming regular activities, especially any kind of lifting. This next section is about irritable bowel syndrome, or IBS. As you study IBS, pull the Rome 4 criteria. IBS is a functional GI disorder, and the hallmarks are abdominal pain and discomfort, plus a change in bowel habits, abdominal pain that is relieved by defecation. The cause is unknown, but keep in mind that there is a brain-gut connection. An example of this is the vagus nerve, or cranial nerve 10, which goes literally from the brainstem to the anus, and it innervates the body through the midsection, heart, lungs, but also the gut from the mouth to the anus. Think about different types of diagnoses such as anxiety, depression, and chronic stress, and often the accompanying GI symptoms that come with that. Patients with IBS typically have two types of complaints. The first is abdominal pain with altered bowel habits. This can be constipation and/or diarrhea. They complain of a pain that generally starts in the left lower quadrant. It might be sharp, burning, cramping. It may be dull, diffuse. It may be constant. It's often precipitated by eating, but it is relieved by passing gas or having a BM. This type of pain usually doesn't wake them up. The second type of complaint is that of painless diarrhea. They typically report an urgent need to defecate either on awakening or after eating. So get a good history using old carts. There is a correlation between IBS and food tolerances. Common triggers tend to be lactose, fructose, sorbitol, which are all sugars, or glutens. Ask about incontinence. This is important. Have you soiled yourself trying to get to the bathroom? It may be embarrassing to them to answer the question, but it's going to give you an idea about the origin of the problem. Ask about any related symptoms such as fever, blood, or mucus in the stools, which can actually point to some sort of infectious or inflammatory process. The lack of other symptoms and signs is what suggests the functional GI disorder such as IBS. Often your exam is going to be unremarkable. They're going to look healthy. IBS diagnosis is based on your history and physical, the pattern of symptoms, increased bowel symptoms with the onset of pain, and relief of pain with defecation. Go ahead and get a CBC because you can check for white blood cell count, which can give you a clue to inflammation. You can check the hemoglobin, give you a clue to any kind of an anemia. The erythrocyte sedimentation rate, or ESR, is indicative of inflammation. A chemistry, urinalysis, you can get stools for occult blood, oviparasites, and cultures if you think it's infectious. The flexible proctosigmoidoscopy and colonoscopy are usually ordered when clinical findings point to other disorders of the bowel, such as cancer, food intolerances, inflammatory bowel disease. You can see your textbook for a list of differentials for IBS. It's pretty lengthy. Management of IBS begins with the diet. The recommendations for diet are between 25 and 35 grams of fiber per day. So a diet high in fiber, that's fruits, whole grains, cereals, and vegetables. You want to introduce increased fiber slowly because fiber produces gas. They've already got a problem with bloating. Ensure that the person will drink 8 8-ounce glasses of water per day. Probiotics can be helpful. Lactobacilli strains, such as this Bifidobacterium infantis, is commonly used. Antispasmodics for abdominal pain are helpful, such as dicyclomine. You can use 20 milligrams 3 to 4 times a day, or hycosamine, 0.125 to 0.75 milligrams twice a day. Some anticholinergics are helpful, and also there's some help with tricyclic antidepressants, or SSRIs, as they tend to calm the bowel. Emotional support is important, and patient education to let them know that irritable bowel is a real diagnosis and how that they can have an improved quality of life by making some adjustments to their diet. This section is on celiac disease, also known as celiac sprue or gluten intolerance. Celiac disease is an autoimmune disorder in which exposure to gluten protein causes an inflammatory response in the small bowel. Gluten is the protein found in wheat, barley, and rye, and is very common in our food. Celiac usually occurs in childhood, but it can occur at any age, and it's often diagnosed in adulthood. Autoantibodies are created in response to the exposure to gluten. Autoantibodies are antibodies against our own body's tissues. These autoantibodies attack the epithelial cells of the intestinal mucosa, specifically the villi within the jejunum. Remember that the small intestine is responsible for most of the digestion and absorption of nutrients in our body. The jejunum is the middle section of the small intestine, just after the duodenum. Chronic inflammation causes atrophy of the intestinal villi, and it's these villi that absorb the nutrients from food. Atrophy causes malabsorption of nutrients and also leads to the symptoms of the disease. There is a genetic predisposition. 2 genes have been identified related to celiac, and that's HLA-DQ2 and the HLA-DQ8. Other risk factors include a family history of celiac, Down syndrome, Turner syndrome, and other autoimmune diseases such as type 1 diabetes and thyroiditis. The clinical presentation is often asymptomatic. We may see failure to thrive in young children who are not gaining weight or growing well. Some patients may complain of diarrhea, fatigue, weight loss, and mouth ulcers. Mouth ulcers are common in celiac. There may be an anemia related to decreased iron, B12, and folate absorption. A dermatitis herpetiformis may be evident on the trunk. This is an itchy, burning rash across the abdomen. Occasionally, there can be peripheral neuropathy, cerebellar ataxia, epilepsy, dyspepsia, and flatulence. Atypical complaints, such as fatigue from anemia or joint pain, depressed mood. Women may complain of amenorrhea, difficulty getting pregnant, or early menopause. Differentials for celiac include inflammatory bowel disease such as Crohn's disease and ulcerative colitis, as well as lactose intolerance. This disease is often misdiagnosed as irritable bowel syndrome. Diagnostics include testing for the presence of autoantibodies. These autoantibodies relate to the disease activity, and they will rise and fall depending on how active the disease is. They may disappear with effective treatment. Testing for autoantibodies has to take place while the diet contains gluten, or the results will be negative. There are 3 autoantibodies responsible for inflammation in celiac disease: anti-tissue transglutaminase, or the anti-TTG, anti-endomysial or anti-EMA, and the anti-gliadin. These are IgA antibodies, and it's important to know that some patients may have an IgA deficiency, so we test total IgA first, because if it's low, the anti-TTG will be low. They'll have a false negative test. The antibody that we test mostly is the TTG. This is the tissue transglutaminase. This has a high sensitivity and specificity for celiac disease. But if the results are inconclusive, then endoscopy with biopsy of the small bowel is indicated. The biopsy report will come back, if it's positive, with classic signs of celiac disease, and that is crypt hypertrophy and villus atrophy. Additionally, we want to test for nutritional deficiencies from malabsorption. That includes hemoglobin, iron, folate, and B12, calcium, and vitamin D. For celiac is lifelong gluten-free diet. Symptoms will improve. Re-exposure to gluten will cause a relapse of the disease. We refer these people to dietitians or nutritionists who specialize in celiac. We also check them for other autoimmune disorders as they tend to occur together. Type 1 diabetes, we test all new type 1 diabetics for celiac. Thyroid disease such as Graves' disease, myasthenia gravis, scleroderma, Addison's disease, which is a disease of the adrenal glands, primary biliary cirrhosis, primary sclerosis cholangitis, and important to know that complications of untreated disease include vitamin deficiency, anemia, osteoporosis, ulcerative jejunitis, enteropathy-associated T-cell lymphoma, non-Hodgkin's lymphoma, and small bowel adenocarcinoma. This section is about bowel or intestinal obstruction. Any condition that blocks the normal flow of chyme, that's the liquid that goes through the intestines, is considered an obstruction. They are classified according to onset, degree, and the effect on the bowel. So they can be acute or chronic. They can be partial or complete. They can be simple or strangulated. So an acute obstruction is that happens quickly from a torsion such as a volvulus, herniation, or intussusception, which is a telescoping of the bowel. Chronic, those are slow, gradual, usually caused by tumor growth or strictures or scar tissue from surgical procedures. They can be partially blocked, as in the case of an ileus, where part of the bowel is not working, or a complete block. Simple obstruction means there is no impairment to the blood supply, such as with an ileus. Strangulated means that the blood supply is interrupted, such as with a twisted bowel or a fibrous band that cuts off the blood flow, and that is a surgical emergency. Most blockages of the intestines are in the small bowel. Most common cause of large bowel obstructions are carcinoma of the sigmoid colon or diverticulosis. The presentation of a bowel obstruction depends on the location of the obstruction, how long it's been going on. Oftentimes, the patient early on will complain of intermittent pain that corresponds to the peristaltic waves. They may complain of vomiting, and as the blockage progresses, depending on where the blockage is, you may have emesis that appears brown and smells like feces. Diarrhea, it may be a complaint, and then as the block progresses, there's constipation and a lack of passing gas. The physical exam is important here. Vital signs, they do not tend to be febrile unless there is diverticulitis. It's important to look at the person. How do they look as they're sitting with you? Do they appear sick? Do they look dehydrated? Get a good abdominal exam. Looking at the abdomen, are there obvious scars? Are there obvious hernias? Is the abdomen distended? Listen carefully. Are there normal active bowel sounds? Are there no bowel sounds or hypoactive? Do you hear some high-pitched tinkling? Often that's what you hear before the obstruction. Just think about water rushing towards a place that has a constriction. It's loudest before it gets there, and then it calms down on the other side. Palpation. If there's an ischemic bowel or perforation, the abdomen is going to be acutely tender. Otherwise, it may be non-tender and there may be no guarding. A helpful diagnostic tool to rule out a bowel obstruction is to do a supine and upright abdominal x-ray. If there is a bowel obstruction, you're likely to see distension of the small bowel. This upright of the patient shows an air fluid level. There are multiple air fluid levels in this particular film. You can see the air areas. They're the light areas there. Within these small loops, And this is caused because as the person is standing up, air rises into these balloon-like areas of the intestine, and that's pretty hallmark for obstruction. Other things that you can get are CBC. If you see leukocytosis, that may indicate impending ischemia from a strangulation. Do a chemistry, especially if there's been a lot of vomiting. Person may be alkalotic and may need some electrolyte replacement. Serum amylase is helpful in ruling out pancreatitis. Differentials vary from volvulus to incarcerated or strangulated hernia, neoplasms, and diverticulitis, and Crohn's disease. As a family nurse practitioner in a primary care area, if a patient presents with this type of pain and you suspect a small bowel obstruction, a strangulated hernia, or anything similar, you're going to send this person out to the emergency department at the closest hospital so they can be hospitalized and evaluated for surgical repair, at the very least for bowel rest with placement of an NG tube and IV fluid replacement. This section is on diverticular disease. The lining of the colon is muscular. Waste is propelled by peristaltic waves. Fiber in the diet helps to keep the intestinal muscles working rather than lazy. Constipation over a period of time can cause the muscle wall to balloon. Small multiple balloons or diverticula are the result. The thing about diverticula is that they do not contribute to the movement of waste. They don't have any muscle in them. They're just simply a sac with a tiny opening that is connected to the colon. Anything that gets into the balloon just kind of sits there. The waste or the seed particles that get trapped in there stay there. Bacteria does its thing and inflammation can occur, and that is diverticulitis. Diverticulosis, the pouches there, the balloons, is painless. It's often discovered when a person has their first colonoscopy. Diverticulitis is different. It is an inflammatory process that can become an infectious process. Infected diverticula cause colitis symptoms. If the diverticula rupture, peritonitis and abscesses can occur. These patients are often very sick when they come in. We will focus on diverticulitis as diverticulosis is asymptomatic. Diverticulitis hurts. Inflammation of the diverticula cause colitis symptoms. It can cause fever and tachycardia. Subjective complaints include left lower quadrant pain that's often worse after eating, diarrhea and/or constipation, the feeling of abdominal distension, and bleeding can occur, which is pretty scary. So get a good history, old carts, past medical history, and previous diagnoses, especially if they have had a colonoscopy in the past with a diagnosis of diverticulitis or diverticulosis. Objectively, they may appear ill. This is a person that may walk very slowly because putting pressure down as they're walking makes their abdomen hurt. That is colitis, and sometimes it can be a peritoneal sign. Signs of peritonitis include low bowel sounds, few bowel sounds, the tenderness in the left lower quadrant with rebound pain and some involuntary guarding. There may be rigidity. Those are more signs of advanced peritonitis and possible rupture. Diagnostics include a CBC. You're looking for leukocytosis, which is an increase in white blood cells with a shift to the left. The hemoglobin and hematocrit, you want to be sure that if there's any bleeding that they're not compromised by having a very low hemoglobin. An abdominal x-ray is good. On these x-rays, you will often see You may see the actual diverticula. Blood cultures if you suspect a systemic infection. Differentials include irritable bowel syndrome, colon cancer, inflammatory bowel disease such as ulcerative colitis or Crohn's, colitis, appendicitis, and even pyelonephritis. Early detection of diverticulitis is helpful. When people are sick with diarrhea and abdominal pain, rest is important. Clear liquids until they can tolerate their diet. You can add fiber to the diet. But I will tell you that diverticulitis is common, especially in the over 60 population. There's also a genetic component. Fiber is not going to cure diverticula, and it will not reverse diverticula. It may help prevent flare-ups of diverticulitis. Antibiotics may be necessary, especially if the person's afebrile. The common antibiotics are amoxicillin plus clavulanic acid, it's Augmentin, or a combination of metronidazole 3 times a day plus Bactrim twice a day for 7 to 10 days, or until the patient is afebrile for 3 to 5 days. The abdominal pain and spasms can be helped by an antispasmodic such as hyoscamine, 0.125 milligrams every 4 hours. Severe cases, you've got to send these people to the emergency department. They may need fluids if they are dehydrated. Often they'll need a CT scan to see if they've got some other kind of process going on. And some individuals with recurrent diverticulitis require surgical resection of the affected area. So it's important to follow up these folks and refer them to GI when appropriate. Inflammatory bowel disease is a chronic immunological disease that manifests in intestinal inflammation. The most common types that we see are Crohn's disease and ulcerative colitis. Inflammatory bowel disease is exactly what it says. It is an inflammation of the bowel. Crohn's disease affects people in 2 times of their lives. The first can be in adolescence to young adulthood, and the second in the time when the immune system starts to age, between the ages of 50 and 80. There's a familial tendency to this disease. The disease, though, is limited to the large intestine. It only affects the colon, the ascending, transverse, descending colon, rectum, and anus. Pain is typically located in the lower left abdomen, and that is where the small intestine meets the large intestine at the ileocecal valve. Bleeding can be common depending on the location of the lesion and the size and the involvement. Oftentimes, a person with significant inflammation will present with fever, malaise, and weight loss. Looking at ulcerative colitis, the difference in the disease onset is from pre-adolescence to the age of 40. Also, there's a familial tendency. This disease can occur anywhere in the GI tract, from the mouth to the anus, with patchy inflammation affecting large sections of the bowel. Pain can be mild, and it's typically in the right lower abdomen. Bleeding is also common, and this disease is characterized by ulcers that can be seen on colonoscopy. The diagnosis of this disease is made by correlating the history and the physical exam. The physical exam oftentimes is not very remarkable, depending on how bad the disease is. But if you suspect any type of bowel involvement, get a stool analysis for blood and mucus, and cultures to rule out pathogens. You're also going to get CBC and a metabolic panel. Oftentimes these diseases cause malabsorption of vitamins and minerals, anemia from iron deficiency, from the inflammation, and poor absorption of vitamin B, including folate and vitamin B12. The differentials, these diseases can look like irritable bowel syndrome, appendicitis, diverticulitis, especially with the pain occurring in the left and the right abdomen. These can look like infectious diseases of the bowel, malignancy, and bowel obstructions. The goal in treating inflammatory bowel disease is to achieve remission. There's a nice chart of the different drugs in Chapter 40 for you to look at. It's good to be familiar with the drugs, although as primary care providers, we will not be prescribing these particular drugs. Most of these are managed by the gastroenterologist and/or a rheumatologist. Ulcerative colitis requires nutritional counseling and to avoid caffeine, raw fruits, vegetables, high fibers that will traumatize an inflamed mucosa. We're going to avoid antidiarrheals. In people with these diseases, let somebody else write the prescription for those. We do not want to cause a toxic megacolon. That occurs when a very responsive, sick colon stops working in response to the Lomotil or the Imodium, and waste products build up and the part of the intestine grows into what we call a toxic megacolon. Advanced diseases usually require glucocorticoids and immune modulating drugs and immunosuppressants. Surgery is curative for ulcerative colitis, as the inflamed part of the bowel can be removed. Oftentimes these people will have either a temporary or a permanent colostomy. Crohn's disease is different. It is not cured by surgery. The treatment tends to parallel ulcerative colitis, but unlike ulcerative colitis, it does not respond to the 5-aminosalicylic acid agents. Glucocorticoids are more productive in management. Surgery for Crohn's disease is indicated when there is an obstruction or fistulas or abscesses or perforation of the colon. Crohn's disease and ulcerative colitis are diseases with periods of exacerbation and remission, and lifelong management is required. These patients are going to be referred to a gastroenterologist. They need nutritional counseling. They're going to need long-term use of steroids and immunosuppressive drugs, which requires a lot of follow-up, including routine colonoscopy. Complications of Crohn's disease are many, including fistulas, both anal and perianal, arthritis, eye and mouth inflammation. This is an immune disease, immune system disease. There are complications that are associated with long-term corticosteroids, whether they're used in ulcerative colitis or Crohn's, and that is osteoporosis and cataracts. And as a primary care provider, you're going to be on the lookout for those complications. This last section is on colorectal cancer. Colorectal cancer is the second leading cause of cancer deaths in the United States. The risk factors include the Western diet, which is high in fat, refined carbohydrates, that's processed foods, red meat, and low in plant fiber. Obesity and being overweight, physical inactivity, these are all associated with a greater risk of developing colorectal cancer. Long-term smoking and heavy use of alcohol are other risks. Other risk factors include family history. At least 25% of people with colorectal cancer have a family history. Having inflammatory bowel disease, such as ulcerative colitis, is also a risk factor. Gynecological cancers, including breast, ovarian, and endometrial cancers, are also risks, and that is because there is a link between the breast and the gut as far as cancers go. Having a history of Barrett's esophagus is also a risk factor. Screening is important. Colorectal cancer is curable and preventable if it's detected early. The adenomatous polyps are thought to be precursors of the adenocarcinoma. 95% of all malignant tumors are adenocarcinomas. Signs and symptoms, most colorectal cancers are asymptomatic until the tumors are large enough to cause problems. You may have a patient with melena or bright red blood, change in bowel habits, that can be diarrhea and or constipation, weight loss, fatigue, and those are late symptoms. That's why it's important to screen and catch these early. Physical exam is often unremarkable until the cancer has progressed to a place where you can feel an abdominal mass or the liver is enlarged. Sometimes you can find occult blood. Diagnosis is made by colonoscopy. Oftentimes, a colorectal cancer is found incidentally. That means that they've gone for colonoscopy and the gastroenterologist has found a polyp and removed it. Or person's having abdominal surgery for whatever, and a large mass is found. There are no definitive lab tests at this point. Later, the CBC may be significant for anemia. Liver function tests may be altered, such as the alkaline phosphatase if there are bone mets or liver mets. A serum immune assay for a carcinoembryonic antigen is not helpful as an early means of detection. It's too insensitive and it's not near specific enough. The CEA can be helpful in monitoring response to therapy because it normalizes after colon resection, and a spike could be suggestive of recurrence. Differentials, think irritable bowel syndrome, inflammatory bowel disease, infectious colitis. Any patient with iron deficiency anemia and a heme-positive stool have a very high suspicion for colorectal cancer, regardless of age. Management of colorectal cancer depends on the staging of the disease. Staging of the disease is done by the surgeon once the affected area is removed. And there is a nice chart in your book on TNM, which is tumor node metastasis description. And what you need to think about as a primary care provider is, what will you tell a patient who comes in and asks you, what does it mean that I have stage 1 colorectal cancer? What does it mean that I have stage 4 colorectal cancer? That's what we need to know about. That's what we need to talk with these patients about. We want to tell people that have, say, a stage 0, that's a carcinoma in situ, that is an encapsulated, one-off, remove it and it's cured, that is curative, versus someone with stage 3 or stage 4 who's undergoing chemotherapy and they've been given, say, a survival rate for 5 years. So we want to be aware of the tumor classification, and we want to know what their gastroenterologist and their surgeons are telling them, and perhaps their chemotherapy docs. Let me say a word about screening and prevention. Screening is not prevention. Screening is done for early detection. So when you're thinking about the levels of care or the levels of prevention, this is a level 2. We cannot prevent cancer by screening for it. What we can do is detect it early and treat it. Prevention are diet, exercise, losing weight, those types of things that I talked about in a previous slide. The screening guidelines have changed in the last 2 years. The initial age has been lowered from 50 to 45. That is because the rate of colon cancer has nearly doubled in people between the ages of 20 and 49. So waiting to screen somebody for colon cancer until the age of 50 is no longer prudent. Prevention. This is where we teach people diet low in fat and refined carbohydrates, high in fiber, fruits, vegetables, and complex carbohydrates, weight loss, and exercise.